Hi, good evening, everybody. My name is Dr. Betty Teh. I'm a consultant interventional cardiologist. We came about this topic with Ellen Teh because in conjunction of World Heart Day, we thought that it could be a good title topic to talk about. And I would, of course, like to extend my thanks to Ellen and Dobbs for allowing this opportunity to actually speak on familial hypercholesterolemia. Okay, let's see. Now, cardiovascular disease is the #1 killer, accounting for 1/3 of all annual deaths worldwide. About 17.5 million people die each year from cardiovascular death, especially so in developing countries. And the number is expected to grow to 24 million in the next decade or so, and mainly because the numbers is growing basically because the numbers in developing countries is also growing. Now, coronary artery disease death make up the majority of cardiovascular death. Now, what is World Heart Day? World Heart Day is a day that we celebrate on the 29th of September each year. It is an event that is organized by the World Heart Federation. Basically, it is to create awareness about coronary vascular disease, cardiovascular disease, and more importantly, how to prevent it, okay? Because we know that prevention is better than cure. Now, before we had Framingham Heart Study, we had not much knowledge at all, okay, about heart diseases. The Framingham Heart Study revolutionized the way we thought about heart disease, okay. It was started in the 40s, okay, after realizing the lack in understanding in heart disease. Okay, let me just go into background and the history of Framingham Heart Study. It is actually a study that was conducted, okay, prospective and epidemiologically in a town called Framingham. Okay, they recruited about 5,000 over patients. Okay, and now it is into the third generation of recruitment from the first cohort. Okay, means that these patients' offsprings and the grandchildren are now being studied in the Framingham Heart Study. Now, before the Framingham Heart Study, we understood very little about heart disease and its risk factors, how it is correlated with heart diseases. Now, going back to 1932, President Roosevelt, who was a wartime president, in 1932, he was campaigning for his first election. At that point of time, it was recorded that his blood pressure was high, but everybody thought that high is normal. It was 160 over 90. They took it as this is normal reading. Okay. By the time that in 1940s, in the second term of his presidency, he started feeling short of breath. The chest X-ray actually shows what we know now as congestive cardiac failure. The presidential physician was not a physician. He was not a medical doctor in the sense that he's not a cardiologist or somebody who understood medicine. He was actually an ENT specialist. And the treatment at that point of time was limited because our understanding of heart diseases was limited. So what happened was he eventually died of an intracranial bleed. And at that point of time when he died, his blood pressure was 300 over 160. Now the next president then decided to have the Heart Act. The National Heart Act started this Framingham Heart Study. Okay, they chose a town and studied about 5,010 patients, okay, over a period of 20 years. And from there, they published a lot of papers. Okay, they understood high blood pressure, okay, not only as a disease that was a precursor to heart disease, but high blood pressure in itself, okay, how it increases the risk of stroke, okay, how we should bring it down regardless of age. So this Framingham Heart Study contributed a lot to society and should be mentioned in our talk in celebration with World Heart Day. Okay. Now from the Framingham Heart Study, we then recognize that heart diseases can be prevented in many ways because we can prevent or modify the risk factors. And the modifiable risk factors are smoking, diabetes, hypertension, genetic, which we cannot modify, of course, hypercholesterolemia. Now, a person that I would like to mention and pay tribute to in conjunction with World Heart Day is none other than my dear friend, Dr. Kukalin. Now, Dr. Kukalin, of course, is synonymous with Yayasan Jantung Malaysia. He basically took a very huge interest in cholesterol. Of all the risk factors, he was very, very interested in cholesterol, so much so that he wrote a book on my cholesterol journey. Now, the sales of the book, from the book, he then donated about 75,000, okay, from the sales of the book to Yayasan Jantung Malaysia. And throughout his life, okay, he was conferred the Research Gold Medal Award by Rotary Club in the field of Familial Hypercholesterolemia. He was also named the Outstanding Person of the Year by MMA. Now, he spent all his life, okay, helping others with this problem. Okay, he was also one of the founding members of South Seng Lam Dialysis Center, where they did treatment for patients with familial hypercholesterolemia, which I would explain later. Dr. Kukalin passed away on the 7th of November 2014. Now, familial hypercholesterolemia is more prevalent than you think. It was previously thought to be maybe 1 in 500, but more recently it's estimated to be about maybe 1 in 200 people in the general population. We think that there are about 34 million individuals with familial hypercholesterolemia worldwide. Now, the mutation that we see, okay, before we talk about the mutation, we must understand the normal metabolism of cholesterol. Now, the cholesterol in our bloodstream, okay, in our plasma is binded to certain proteins. So we have the low density lipoprotein, we have the high density lipoprotein, we also have the very low density lipoprotein. For it to be metabolized, the cholesterol then needs to be binded to the LDL receptor. There are many other receptors that are involved and many factors that can actually change the metabolism rate of cholesterol. But the most common mutation we see is actually when there is a mutation in the LDL receptor. Then the LDL does not bind to the mutated LDL receptor, and there will be accumulation of LDL in the circulation, and then this cholesterol will cause premature atherosclerosis. There are other mutations seen in other genes, and there are actually 1,000 forms of mutation even in just the LDL receptor alone. Okay, a dysfunctional ApoB results in limited binding of LDL-C to the LDL receptor. Okay, PCSkg PCSK9, when you have a gain in function in PCSK9, you actually then see an increase in your cholesterol in the bloodstream because there is reduced LDL receptor function. Now, what is PCSK9? PCSK9 was recently discovered to be a key player in the metabolism of LDL cholesterol. It regulates the level of LDL receptor and the membrane. A gain of function in the mutation of PCSK9 reduces the number of LDL receptor. Now, loss of function in PCSK, on the other hand, increases the number of LDL receptor. And this is important because this knowledge then help us in the therapy of patients with high cholesterol. Now, familial hypercholesterolemia is inherited, and it is inherited autosomal dominantly. If you actually inherit one gene, you have half the number of LDL receptors, and you are likely to have 2 times the increase in plasma LDL level. If you are homozygous inheritance, you will possess 2 mutated genes and you will have less LDL receptors, and therefore your LDL plasma level may be 4 to 6 times that of a normal person, and you have a worse prognosis. Now, genetically, the LDL receptor gene is located in the chromosome 19. A single mutation in a heterozygous familial hypercholesterolemia will have an increase of 40% risk of cardiovascular disease by the age of 50. And you have a double mutation in a homozygous person, it will cause premature atherosclerosis and can present with complications during even childhood. There are about 1,000 mutations known for LDL receptors alone. Now, as you can see here, this is a chart where the diversion of patients with FH and without FH in both men and women can be seen as early as in their 20s. The red curve shows patients with familial hypercholesterolemia, and the blue or the green curve line shows that of a normal person with normal cholesterol. So they start diverging, means they start developing coronary artery disease at a much younger age group, even as early as in their teens or in the 20s, even if in heterozygous familial hypercholesterolemia. Now, as I just mentioned, most of the patients with FH are because of a mutation in the LDL receptor, 70% of them. A small percentage of them will have mutation in the PCSK9, where they gain a function in PCSK9, therefore there will be a reduction in the metabolism of LDL cholesterol. But there are about 25% of patients that have familial hypercholesterolemia that we do not understand yet. They could be autosomal recessive kind of genetic disease, but the understanding is not there. We do not have any studies, or we don't have enough proof of the genetic understanding behind these patients. Now, when you look at patients with young adults with myocardial infarction or any cardiovascular disease for that matter, always think of familial hypercholesterolemia, because they are very common. Especially if you can get a family history of an immediate family with premature cardiovascular disease. Now, how is the diagnosis made? The diagnosis is made from one, okay, you do not need genetic testing. One is the cholesterol LDL level. A cholesterol LDL level of 4.1 in children with or without family history of premature cardiovascular disease, okay, or an LDL of 4.9 for adults. Now, if you have one of two parents with clinically diagnosed familial hypercholesterolemia, okay, positive genetic testing, okay, may not be necessary, okay. Usually it is very rare for us to send patients for genetic testing. It's costly, it is not a test that is commonly or easily available. So most diagnosis is actually made from clinical criteria. Okay. Now this is a very high risk disease, means there's an increased morbidity and mortality. But what is good, the good news is that early identification and diagnosis with appropriate treatment can reduce the morbidity and mortality drastically. How is the diagnosis made? Again, just now I mentioned from physical examination, following which you look for, let's say, xanthoma, xanthelasma, okay, a good medical history of personal and family history of elevated cholesterol, premature or early cardiovascular disease, and then of course a basic LDL level. Now, how do you approach a patient, okay, after identifying this patient to have familial hypercholesterolemia? So now you have identified the LDL level, okay? Any LDL level of 4.9 in an adult or any LDL level of 4.0 in a child of 16, always think of familial hypercholesterolemia. Chances are they have this genetic disorder, okay? What degree of abnormality, okay, it is difficult to say, but then from this level, get the family history. The family history is either a first degree relative of with an LDL of 4.9, okay, or a positive family history could be, okay, early cardiovascular disease before the age of 60 for women and 55 for men, or any clinical signs of deposits, either xanthomas or arcus or xanthelasma. Now, always do a thorough examination of patients, and then you come to a diagnosis of familial cholesterolemia. Now, then always take other risk factors, okay, into consideration, because once you have a high LDL level, okay, you have an increased risk of cardiovascular disease. But when you have ongoing and added risk factors like hypertension, diabetes, okay, and smoking, then your risk of cardiovascular disease multiplies, okay, as you can see in this graph. Okay, now how do you treat these patients? Now, the thing about treatment is not just bringing down the LDL level, but bringing down the LDL level for a long duration of time, as long as they need it, as long as their life depends on it. You must bring out the LDL. Okay, so actually counseling the patient is not an easy task, okay, because you need to tell them this is a genetic disorder, the treatment is for life, okay. So, and worse, you have to treat at such an early stage of their life. Sometimes patients start treatment during their childhood, and you need to actually achieve an LDL of less than 3.5, okay, the moment they are more than 10 years old. So the therapy is this. Usually a high potency statin, okay, it can be of any statin, okay, and to the level that they can achieve, okay, because you can have statin up to 80 milligram of atorvastatin, but if they have no symptoms, titrate your statin to the maximum. If the LDL level is not achieved, then you would like to add something else, maybe an ezetimibe, okay, and then sometimes the LDL level can be 8 or 10, and it's not likely you're going to bring it down with just oral medication. Now you need to think of PCSkg9 inhibitor. Now Dr. Kukalik spent a large part of his time, okay, collecting data and also trying to treat patients with familial hypercholesterolemia. At that point of time, okay, we only had statin. Then later we had azithromycin. We never had PCSkG9 inhibitor until much recently. So how did he treat these patients? Okay, and how did he help them? Okay, we had the only plasma apheresis treatment in the Southeast Asia, thanks to Dr. Kukalik. It was located in South Seng Lam Dialysis Center, and this plasma apheresis is where it is like a dialysis machine, but the filter actually filters off the apoprotein. Okay, and then it can effectively reduce LDL level by 50 to 60%. However, like dialysis, it had to be done on a regular basis. It was very time consuming and it was very costly. So it was a very difficult treatment for a lot of young patients, especially school-going patients. But thanks to now PCSkG9 inhibitors, okay, the development of which has revolutionized the landscape of lipid management, it is extremely effective. You can see a reduction of 60% of LDL-C, okay, regardless of the cause, and okay, it can be administered by the patient, and it is a treatment that can be done every 2 to 4 weekly. So if you are a general practitioner, one, it's very easy for you to dispense the medication. You can actually teach the patient self-administration. Even if the patient is not comfortable with self-administration, they can actually come to your clinic because you can administer for them, because it is so easy. They don't have to come on a such regular basis. They come twice a month. And let me just skip this slide. Okay, so actually genetically, when you have PCSkG9 gain in function, okay, you actually have reduction in LDL receptor. But now we inhibit this PCSkG9, and then so there will be an increase in LDL receptor, and then your LDL level in the serum reduces, and of course your risk of coronary artery diseases can reduce, and it can be reduced as much as 80%. Now, what is the ESC guideline for LDL cholesterol? Even in the last 3 or 4 years, the guideline has changed. Okay, we all look at risk factors. If you have very high risk factors, it used to be the LDL level, we want to bring it down to 1.8 in 2016. Now the LDL level should be less than 1.4 if you're of very high severe risk. Okay, you want to target most patients with an LDL of 1.8, okay, if they have already an event. Okay, if you have low to moderate severe risk, you should target an LDL level of maybe 2.6 to 3. It is not all that difficult to achieve, neither is it very easy to achieve, but we have a lot of options from medication that we can dispense. Okay. For patients with a history of CVD, okay, who experience a second episode within 2 years, okay, it is said that you need an LDL level of less than 1. Now, for secondary prevention, patients with very high risk, okay, not achieving their goal on a maximum tolerated use of statin or Zitrol, a combination with PCSkg inhibitor is recommended. And now we stick to the topic of familial hypercholesterolemia. So a very high risk of patient with FH, okay, a patient that already had an event who do not achieve their goal on maximum tolerated dose of statin and Zitrol, a combination of PCSkg9 inhibitor is recommended. And this evidence is based on class 1's level of evidence. So what is Repata? Repata is a fully human monoclonal antibody that binds to PCSkg9. It is a very safe treatment, okay, and it can bring down the level of LDL by 60%, which I've already mentioned. But can this LDL be too low? If you're too worried, okay, studies have demonstrated that it is possible to reduce LDL level to as low as 1.4 using PCSkg9 plus statin plus Zitrol with no problems, no complication or side effects whatsoever, and LDL level can be very low with no effect on the patients whatsoever. So it is safe. Okay, do not worry about the LDL level. Always worry about the events and the eventual events that may happen and the eventual events that you may be able to reduce by proper treatment. How do we adhere to this treatment for familial hypercholesterolemia? Now you have heard me mention statin, Zitrol, Repata, but counseling is also extremely important because this treatment have to be commenced from a very young age. Okay, and then you not only have to commence the treatment in the patient, you have to screen all the family relatives, and then you have to decide, okay, because it's a familial disease and it is inherited dominantly, many family members will then have these problems and they also have to need this treatment regime. Okay, and parents have to understand, okay, because the children may be very well. Okay, it is not a disease that causes deformity unless you have xanthomas. It's not a disease that can, okay, affect the child's development. So parents have to actually counsel for this treatment. And it's going to be a costly treatment, no doubt about it. Okay, and then you need to counsel patients for self-treatment. They need to be confident in their ability to manage their own condition. Okay, and then they need, of course, this is all done, okay, because we need to have a formal diagnosis. So therefore, so that we can actually counsel them. So we have to also counsel them, not just for management, but also counsel them during the time when we do the diagnosis. Sometimes reading materials, is important. getting them connected to the right people, okay, the right resources and support for the lifestyle treatment, okay, and the fact that we should create a positive relationship between us and these patients and their family is extremely important. So in summary, familial hypercholesterolemia is more commonly is more common than previously thought. Okay, and familial hypercholesterolemia is actually a very manageable condition these days. There is no need for a dialysis center. Okay, an injectable treatment that is 2 to 4 weekly can bring down a cholesterol level by 60%. It's a very good treatment option. There are many new developments in this treatment option. Many new agents are coming up. Okay, and then long-term adherence to drug therapy is key to the management of patients with FH. Okay, and early identification of treatment of patients with FH is necessary to reduce morbidity and mortality. Okay. Always take a good family history, and with that, it is very easy to make a diagnosis. And in conjunction with World Heart Day, I think we should, as doctors, be more aware of FH, okay, how we can actually contribute to the prevention of patients with cardiovascular diseases, and we would like then to create awareness in us and also the society that we eventually will manage, okay, and also pay tribute to people and studies that have contributed to our understanding, the treatment of patients. And with that, I would like to thank you for listening to my talk, and then we will take questions as we go along. Thank you.